My background is as a clinician. I led the National Aspergillosis Centre at Wythenshawe Hospital in Manchester for about 10 years and worked at the University of Manchester for a long time, done a lot of research on different aspects of fungal disease. And what I'm going to do today is to just really skip over the surface of this really quite big and evolving area. I'm going to cover four broad areas. The last is very brief because that's a topic that you know pretty well, I think, and we've just published on that, so it'd be helpful for you. But how many fungal infections are there around the world? Who gets them? Climate change, a little bit related to that, nasal resistance, and then protecting patients. So about a year ago, I published this paper, which was this combination of about 10 years of work trying to work out how many fungal infections there are in every country, including the UK, and we published that with what was then the HPA in Manchester about 5 years ago. And it looks like there are an annual incidence of about 6.5 million potentially lethal fungal infections. So this ignores thrush, it ignores ringworm, toenail infections, and all that sort of thing, and most of the allergies as well. But these are the ones that really kill people. And of those, about 3.8 million deaths probably, and about 60-something% are attributable. So if you have end-stage leukemia and you failed all your chemotherapy and you're put in the palliative care pathway, and then you get candidiasis or invasive aspergillosis, that's not a death due to the fungus, that's a death due to the leukemia. But 60% are probably due to the fungus in that context and other contexts. So there are four buckets here to make life easy. Invasive aspergillosis is probably the largest problem globally, with multiple different underlying diseases. You all know about the leukemic bone marrow transplant patient, but actually there's a lot of other patients that get invasive aspergillosis, including lung cancer patients and patients with COPD and in intensive care. And I'm going to overview those a bit. But you can also see on this graph that the majority of these patients probably die. And the reason for that primarily is a lack of diagnosis. We do not suspect the test that the patient has the disease, and we don't request the right tests, or if we do, it's too late. So there's a problem with a lack of suspicion. So one of the big groups in this is patients with COPD. So globally, the WHO thinks there are roughly 200 or 300 million COPD patients. We did an analysis and it's about 500 million. Whatever it is, it's a very big number globally, mostly related to smoking, but not completely, and probably around 58 million admissions to hospital every year. I mean, just a giant burden on healthcare systems across the world, including the UK. And one of the drivers for that, and this is a new piece of work from Singapore and Vancouver, is actually home exposure to Aspergillus. So this piece of work looked at what the risks were, and they did a multivariate analysis, and you can see the FEV1, which is your smoking, whether you're a smoker, how heavy you are, your age. But the big factor was actually Aspergillus and having Aspergillus in your environment. And that's measured on the right-hand side. ASPEF3 is a proxy for how much Aspergillus is in the environment. It's a protein produced by Aspergillus. And your lung function is really reduced if you've got Aspergillus in your environment, and your chance of coming into hospital with an exacerbation is greatly increased. So it isn't just in the hospital, there's also community acquisition of these infections and problems, and that's a big deal. So if you take this group of patients who come into hospital with Aspergillus, two studies, in fact there are about 5 or 6 studies now, one from Spain, about 1.3% so have invasive aspergillosis. So that's sort of around 1 in 40-ish, 1 in 60 patients, something like that. So if you're doing ward rounds post-medical take and you've got 4 of these patients, the chance on a given day is quite low, but every 2 or 3 weeks there'll be one of these with invasive aspergillosis. And the Chinese rate was nearly 4%, so rather high, so 1 in 25 in that. And the mortality rates are pretty high. So the clues to this, and I know most of you are not seeing the patients directly, but it's important that you understand that this is numerically a very big problem and needs addressing. These are technically gold stage 3 or 4, so that's the worst group with COPD. People with wheezing, and sometimes they have airways disease, not pneumonia. Worsening infiltrates, so most COPD exacerbations don't have an abnormality on their chest x-ray that's new. If they have a pneumonia or a bilateral pneumonia, that's very likely to be aspergillus. Culture of aspergillus, of course, high steroids. Steroids are a major driver for aspergillosis, both acquisition of disease, and if you're still on steroids, if you have the disease, a worse outcome. It increases the death rate by 2 to 3 times if you're on steroids on treatment. And then most of these patients don't have a fever. So you can't go around saying, oh, they've got fever, therefore we can exclude it. You can't do that. In intensive care, the estimate is about 500 million people get invasive aspergillosis on ICU. Some of that's influenza-driven, some of it's COVID-19-driven, but most of it's just medical patients ending up in ICU with an episode of sepsis, a bit of diabetes, a bit of COPD, a bit of this, a bit of that. And it's not the surgical patients, so these are the medical ones. And if you do a bronchoscopy in ICU, you double the chance of making the diagnosis. So one of the bits of advice that's come out of some really good work in Belgium and Holland is that new medical admissions to ICU should have a bronchoscopy. It should be a routine procedure looking for fungus and looking at the airway. And although many of them are super sick and very oxygen dependent, you can actually do a quick bronchoscopy, and that needs to become part of routine care in this country, and it isn't at the moment. And this big study from Spain, a big autopsy study, found 2.8%, so running roughly 1 in 40 medical ICU patients with this disease. And if you have VAP, a UK-based study read by Ronan McMullen in Belfast, found that 12.5% of the ICU patients with VAP had invasive aspergillosis. So that's a group that particularly needs attention. And the problem for us from a diagnostic perspective is that the radiology is not very distinctive. These x-rays could be from any sort of pneumonia, any sort of infiltrate, a bit of this, a bit of that. The one on the bottom left is a bit more distinctive with these nodules, but the rest of them are not very distinctive. So radiology, which we use a lot in other contexts, is not very helpful in ICU. The second large group of infections is Candida infections, as I'm sure you know, and probably about 1.5 million people globally with this problem. And this is a lot of different types of patients. So premature babies, patients on cancer chemotherapy, diabetics are particularly at risk. Those with major surgeries, so really big surgical procedures of different sorts, particularly abdominal ones, major trauma, burns, renal failure is an exacerbator of this, and then every course of antibiotics which is added increases the risk. If you have 3 classes of antibiotics given to a patient, you double to triple your risk of getting candidemia. So antibiotic control and stewardship is a big factor, prevention factor in this area. And also hospital transmission is another big factor. Pre-Candida auris, around 10% of cases were hospital transmitted, probably on healthcare workers' hands. Now with auris, it's larger than that. And we're seeing Candida parapsilosis increasing in many parts of the world, and it's fluconazole resistant, which is new. So this is a big problem. About 2/3 of these patients probably die, and the part of the problem is that the blood culture is only 40% sensitive. Only 40%. So the glucan assays and other means, colonization indices, are ways of trying to make the diagnosis. And then there's another group who have chronic pulmonary aspergillosis, and I won't dwell on this because this is primarily an outpatient problem, but it looks like TB, very similar to TB. They cough, they lose weight, they feel tired, and they may cough a bit more blood up. And the key test for this is an Aspergillus IgG, or antibody test. So the antigen test is particularly useful for invasive disease. For this more chronic indolent disease, it's the antibody test is important. And the problem we have generally with Aspergillus is that the cultures are pretty insensitive in the laboratory. So in our centre in Manchester, we had a lot of patients with chronic pulmonary aspergillosis and also allergic aspergillosis, and we routinely did cultures. And we would send them off to the lab, and the lab would process them in the category 3 lab, mix it with sputazole, plate it, and they would plate 10 microliters in a typical thing, and then you can pick the bacterial colonies from that. But for fungus, that gives you a yield of about 20%. And if you do a high volume culture where you do the whole specimen on the plate, you can push that up to 60%. So triple the yield. So one of our problems is people request culture, and we need to request fungal culture, because fungal culture, the plates that we used increase the yield by about a third. And then if you can transform to a high volume culture, you push that up even further. And that allows you to grow the organism, which otherwise is quite difficult to do. And so if you take chronic pulmonary aspergillosis, about 1.8 million globally, a lower acute mortality, but loads of morbidity. These patients are really poorly and can't work, can't do much, coughing up blood, and so on. And it's primarily related to prior TB, NTM disease, smoking, asthma, lung surgery, etc. And then we've got Candida auris. So this is now spread around the world. This is a map of a few years ago, and you can see the gradual progression. The first case was in Korea in 2008, and it's been gradually increasing across the world. And this study from Pakistan, small study, but very illustrative, 86 cases of COVID-related candidemia, because during COVID we had more candidemia cases, we had more aspergillus cases. And of those 86 cases, 10 were Candida auris, all of them fluconazole resistant, and 67% of them died. Not great, not something you want. And in the UK, we've seen a gradual increase in the number of isolations of Candida auris. It comes in waves. It's very much a hospital outbreak problem. This organism behaves like MRSA. It colonizes the environment, it colonizes the skin. You should need to think of it not as the old style of candidas, which are only in the blood and in our guts. This is a sort of MRSA lookalike, but it's a multi-drug resistant one like MRSA is, and it's difficult. And fortunately, most of the isolations are not in blood, but there's the potential to get into blood, and the situation with that is bad. It seems to be Southeast London focused, and now, just this month, it's now a notifiable disease. So there's an obligation on all hospital labs now to report Candida auris to the Health Security Agency, and that's an important new finding. And then finally, the last group of patients with severe fungal disease, about 1 million of them, are pneumocystis pneumonia, cryptococcal meningitis, mucormycosis, histoplasmosis, those types of conditions, and that's probably about another 1 million people. AIDS is a big factor there, diabetes is a big factor, but also cancer chemotherapy and severe asthma is also a thing. So patients die of fungal allergy in severe asthma, particularly if it's not handled, and about 60% dying in that group. Now, not on that list is this problem, which is a problem that's emanated from India, a ringworm, resistant ringworm. So many of you will have had athlete's foot, and you will have taken Lamisil cream and put it between your toes, or treated your kids with it, or family members with it. And Lamisil or terbinafine has been an absolutely workhorse antifungal for skin fungal infections. Very useful, non-toxic, very helpful. But in India, they mixed it with steroid creams and antibiotic creams and splashed it around. Many of the concentrations used on the skin were very poor, and they've evolved, and it's a new pathogen, a new resistant dermatophyte, Trichophyton indotinei. And this is completely resistant to terbinafine. The fungus is much more virulent. I mean, I don't know what you'd feel about if you had one of these rashes. You wouldn't feel comfortable about it. You certainly wouldn't go and would be happy about it. And then they failed terbinafine, and even with high-dose itraconazole, that is 400 a day for 6 weeks, only 75% respond to that. So this is a very difficult infection. And it's now the commonest presentation in India. If you see patients with dermatophytes in this country, of Indian, Pakistani, Bangladeshi origin, they may have this infection. And there is very little testing done across the country, so it's quite difficult to sort it out. There are molecular tests available, which are quick, and that's helpful, but otherwise you just get a trichophyton culture and you don't get a susceptibility test. So one of the things that the Health Security Agency and the reference labs in Britain need to do is they need to start doing testing for dermatophytes. And we're also seeing resistance in Trichophyton rubrum, which is the older style common pathogen as well. So there is going to be, and has already been, a change in fungal disease related to climate change. You've got temperature increases, you've got extreme weather, those forest fires with all that smoke in the air, loads of fungus in that smoke which is breathed in. You've got homes damaged by terrible flooding, and you get mold growth inside the homes as well. And then we've got spillover of antifungals into the environment, which are leading to resistance in the environment. And so there's lots of different aspects, and I don't want to dwell on these because they're not very relevant for most of UK practice. But just to realize that the world is changing in many ways, and the fungal world is changing as a result of climate change. So here is, this is in the wrong order, this was the high volume culture, let me take that. What about resistance? So we're also seeing resistance in Aspergillus, which is growing, and there are particular parts of the world where this is a problem. This is an e-test example. Most of the work is actually done with microbroth, microdilution. This was the situation in the Netherlands with increasing resistance rates across the Netherlands, reaching not quite 10% across the different countries. And this was very much related to tulip bulbs and spraying azoles on the tulip bulbs. And then when you last bought tulips, but they only have like one of those brown coats on them instead of multiple layers, and they would take those off, those brown coatings on the surface, and they would be full of azole, absolutely full. And so they had these hot spots of azole resistance in the Netherlands. And this is, the flower bulb farms have really driven this in the Netherlands, and now it's endemic and exists in the soil all over the country, and it pops up in different patients. And it's this relationship with the azole usage in fungicides is well demonstrated in this study from China. So if you look at the graph on the right, you can see that as you increase the amount of fungicides in the soil, you also increase the proportion of isolates that are resistant. So there's a direct correlation between spraying our crops with azole fungicides, which we do, and there are about 100 different azoles fungicides that are used, and the development of resistance in crops. And in Britain, the data from a citizen science project that was recently done from Imperial with Jan Shelton showed about 14% resistant. So every time you have an aspergillus that you intend to treat in the hospital, you need to susceptibility test it. 1 in 7 level of resistance is too high to say, oh, it'll be fine. Right? It's not acceptable anymore. We need to test. If you're going to treat the patient, we need to test. And we also need to worry about chronic disease because you can get emergence of resistance on long-term therapy as well. And this study from Vietnam, southern Vietnam, Mekong Delta, is pretty scary because they did a lot of work on fumigatus itself, and they found 95% of their strains resistant. 95%. That's really high. Right? And this is very concerning. And it's about 50% of Aspergillus flavor strains in the same area. So finally, Sharon Bamba, who is a IPC laboratory person based at the Wirral, is doing her clinical science training with me and others, and she assembled all of the global guidance about protecting our patients in hospital from Aspergillus. It's in 3 broad groups. There was the clinical guidelines, the IPC guidelines, and the building design guidelines or guidance. And you can see that there is guidance from Britain. There's 1, 1, and 4 across the bottom, and there's other guidance there. But if you have a look at this paper, you'll see that there are giant gaps in how guidance, what people do and don't recommend. Should flowers be in the rooms of leukemics? No. What about patients in ICU? What about neonates? There's lots and lots of uncertainty and variation between all these levels of guidance. And furthermore, there's loads of countries with no guidance at all. In most of Africa, Namibia is an exception, South Africa an exception, but most of the world, most of the poorly developed world has not got guidance. So I'd encourage you to look at this, and I think there's going to be a need to revise British guidelines on the back of what we've discovered about what other people put in their guidelines compared with what we've got. So in conclusion, serious fungal infections are both increasing and increasingly recognized and diagnosed, and that's because of much better diagnostics and the application of diagnostics, but there's a long way to go. Antifungal resistance is now pretty common and needs to be tested for. Climate change will bring additional challenges in multiple different ways, extreme weather being one of those examples. And vulnerable patients, as I don't need to tell you, need protection, especially in the hospital. Should you be interested in more on aspergillus, we run the aspergillus website, which has got loads of presentations, papers. It goes back 25 years as a huge repository of information in that area. And we also run the life educational website, fungaleducation.org, with lots of videos and about lab procedures and about the diseases. Every guideline that's been produced is on there which relates to fungus, and we hope that will be helpful. Thank you very much.